Welcome to the Cyber Health Podcast. I'm Stephen Perano, your host, and we're excited for this episode. Today in the studio, we have a head and neck surgeon who specializes in cancer and reconstructive surgery. Please help me welcome Dr. Yamil Selman to the podcast.
Thanks, Stephen. It's great to be here.
Thanks for being here. So we're going to bounce around a little bit in this interview. And to preface this interview, I'm a comedian. Some people may not know. So disclaimer, we hope we don't offend anybody. Some of it is humorous. You should be able to figure that out when we're joking around. But really, this is a very serious topic. He's a serious person, and he also doesn't know me very well. So this is going to be an opportunity for us to get to know each other and for hopefully you viewers at home to learn a lot about his specialty. So, Doc, let's start off. Where are you from? What's your background?
So I was born in Miami, born and raised in Miami, Florida, and grew up there, went to high school at Southwest, a normal public high school down there, and then went to college at the University of Florida, where I studied biochemistry, did a little bit of biomedical, mostly cancer research while I was there. From there, I went to graduate school for a year at Georgetown and got a master's in physiology and biophysics. Then I took another year to do a little bit more breast cancer research down at the University of Miami, and then eventually ended up at the University of Virginia for medical school for 4 years, and then chose, to become an ENT and ear, nose, and throat surgeon. Did my training at the University of Miami in Jackson for 5 years, my residency down there, and then had an interest in head and neck cancer, reconstructive surgery, sort of cancer care and cancer patients during residency, and so I did additional advanced training in head and neck cancer surgery along with reconstructive surgery at Thomas Jefferson University in Philadelphia, and then moved back down to South Florida and started practice down in Broward.
Nice. So we couldn't get rid of you, right?
No, yeah.
So you would say you're a Miami boy through and through.
Exactly.
Right?
I spent enough time there to know that I wanted to get away for a little bit, and then eventually I think it, like many people, it brought me back.
Right. Well, this is the part of the episode where we're going to do some speed questions. And just to set this up, these are not my questions. These are questions that were given to me to ask Dr. Selman here. Okay, so you ready? Here we go. First one is it true that you were an extra on Miami Vice?
No, but I wish it were true.
Okay.
I'm working on it, though. Still not too early. It's not too late.
I can't see anything. All right. Second question. As I understand it, you wanted to be a GYN, but once you found out how many times you had to wash your hands, you decided to go to head and neck.
Yes, and I also decided that the minimally invasive approaches to gynecology, through the nose and getting to the uterus through the ear is a much better way to do it.
Right, that's right. Okay, next question. Your favorite color is pink, but a hard pink.
Can't argue with that.
Okay, let me see here. I don't see this. These are hard to read here. Let's see this one here. Okay. How old were you when you got your first Cuban link?
9.
9 years old. You're not wearing one now?
I'm not, but I was late to the party. I should have had one at 5 or 6.
Okay. Yeah, well, something else. What side of the bed do you like to sleep on?
If you're facing the bed, on the left.
On the left. So are you not one of the guys like to sleep close to the bathroom?
Nah, not yet anyways.
Not yet. Okay, let's see this one. What's your favorite music or music artist?
Oh, I don't know. I have, and my OR staff will laugh about this, but I have the most random playlist of all time, and it's 36 hours long, right. And it spans Baroque to classical music from the 1790s to like political Argentinian tangos from the 30s, underground drum and bass, salsa, hip hop, everything in between. It's random.
Oh, all right. So what about in your car? Like right now, you're driving.
Same playlist.
Same thing.
I'm a very boring guy. But it is a 39-hour.
So you can't pick just one.
I can't pick just one. I have to listen to everything.
Well, then, do you like Mr. 305?
Yes, I think he's an excellent guy.
Okay. Now, final question for now: is it true that you have a family of roosters living in your backyard?
Not anymore.
Okay.
But when I was growing up, there definitely was. And my grandfather had not a family of rooster; he had a metropolis of roosters. So, yes.
All right. We'll get back to those questions. We have some more. Now, this is a physical one. I'm going to show you something here, and I want your what does this come to mind when I show you this?
This is a tongue depressor.
Tongue depressor. Okay. And what would this be used for in your practice?
To examine someone's oral cavity.
Okay. And do you mind? Can I have an oral examination?
Sure.
Do you mind doing that? Okay.
Let's do it.
Yeah.
Say ah, oh. Close your mouth about halfway. A little closer, perfect. Lift your tongue all the way up. All right.
Okay, great. Thank you so much. How much is the copay for that?
Your insurance will get a bill. It's probably going to be $9,000.
$9,000. Okay.
Yeah,
See that money? He's
specialty.
He's
skills.
reasonable. He's very reasonable.
Yeah.
So now, moving on, thank you for your candor and your honesty with the questions. But everyone's curious to see your surgical skills. I want to see your surgical skills. So the only way we can do that is by bringing
that
up
is
the
amazing.
operation. Okay. I'm going to get this set up here real quick.
This is way harder than actual surgery.
We are not violating HIPAA by any means.
No.
No patient information on the table.
He consented, clearly. Look at his face.
Let me get some cards here. I can tell you which one we're going to do.
This is actually much harder. Can we get the microscope in the room?
Yeah, can we get the microscope,
I need a head and
please?
neck tray. I need a microscope. And we're going to need lots of things here.
Lots of things. Okay, so all right, let's go for the funny bone. The funny bone is the hardest one, supposedly. So we're just gonna move on to the funny bone.
That's
Yep.
this one, this wishbone looking thing?
Yeah, the wishbone.
Yeah, there you go. All right, so what we're going to do is we're just going to mobilize it and do a little dissection.
Oh,
There you go.
Okay.
These are absolutely deplorable conditions. Nope. These are not my pickups.
Get him some different pickups, Monica.
Mm-hmm.
Okay.
Monica, I told you to repair these last week. Yeah.
That's the hardest one.
He's coding. Oh my God, this is bad.
You can do it.
How long is the podcast?
Oh, we have 5 minutes. You're doing great. Keep it going.
I'm afraid this is gonna have to be done prone.
All right, we're gonna bring the position. Oh, here we go.
Nope. Oh, almost got it. It's not.
You got it. You got it. You see it.
There we go. All right, we have it partially out now.
Nice. All right.
Finally.
Got it. All right. What is it about head and neck that really caught your eye?
Yeah, so initially, I would say that in medical school, I kind of got attracted to the ear, nose, and throat specialty by virtue of the anatomy, and it's basically getting everything that's in the neck and the face, the mouth and the throat, the base of the skull, and everything. The anatomy there is really quite complex. It's one of probably the most anatomically complex and dense areas of the entire body, and so certainly the idea of being able to maybe disassemble all of that and then reassemble it was certainly intriguing to someone who's an impressionable medical student. That's kind of what got me interested in the specialty, so I matched in ENT for that. And then during residency, you kind of always survey all of the subspecialties within a given specialty. And so I would have rotations that were dedicated for ear and hearing and balance surgery, or facial plastic and cosmetic surgery, head and neck cancer and reconstruction, pediatric otolaryngology like tubes and tonsils and things like that. Advanced sinus surgery and skull-based surgery, even sleep and then difficult airway surgery and all that kind of stuff. And so in residency, you kind of have a good broad survey of all of that. You get, basic training and all of it. And then usually you make a decision as to whether you want to do a little bit of everything or whether you want to really become a subject matter expert in a relatively narrow field of sort of chief complaints from the patient standpoint. And so I really identified with taking care of cancer patients and sort of the complexity, the difficulty of those problems, the sort of life-saving nature of the surgeries and things like that. And then, of course, the care that the patient gets throughout their entire sort of encounter, right? Their first diagnosis of cancer, the treatment, and all of the things that come with that, and then recovery and survivorship with these very, very long relationships that I have with patients. I'll follow most of my patients for life. Wow. So that's kind of what attracted me to end up as a head and neck and reconstructive surgeon.
That's very impressive. So you weren't just hanging around watching TV, picking your nose. You were very busy.
No, I took picking my nose to the next level. I'm a professional.
Right. Speaking of that, like I said, we're going to bounce around this interview. But somebody wanted me to ask you about vertigo.
Uh-huh.
in the regards to where people experience it for a little while, then it goes away, and they're not sure. Can you comment about that?
For sure. Vertigo is a very challenging sort of symptom, I would say, and I would caution patients with thinking that it's a diagnosis. People say, well, I was diagnosed with vertigo. Vertigo is a symptom of basically an imbalance in the head and neck's balance center. So it's very, very deep in the inner ear. You have you have 3 semicircular canals on either side, which basically detect rotation of your head, and they keep your eyes, oriented, and they, it's a very important function. When that sensory system kind of becomes dysregulated or has a problem, the asymmetry, those 2 sensors not talking or not being in agreement, make your brain feel like you're spinning. And I would certainly specify that vertigo is a rotational spinning sensation. It's not like you're on a ship. It's not like, you're lightheaded. It should feel that the room is spinning, and you can almost sort of tell which direction it is. I would say the main thing to do with vertigo is to see somebody who's experienced with that and can ask you the right questions and do the right physical exam to see what's causing the vertigo. There are viruses, inflammatory processes that can cause vertigo. There are other, chronic processes of the ear that can cause vertigo, medication side effects, and things like that. And a couple of other, kind of a little array of different problems. The good thing is that if you see somebody who knows what they're talking about, I'm not a vertigo specialist, but you see somebody who knows and understands and regularly manages vertigo, someone like an ear surgeon, they will, be able to get you really quite good treatment for it, because the appropriate diagnosis there really lends itself to effective treatment for a really, really difficult problem for most people.
So is it true that a lot of people experience what they call a stiff neck syndrome? Do you ever have that? People come into the office, say, I have a stiff neck, my neck is feel like it's rigid?
You can. Certainly, I would say that's a pretty common complaint. There's a little bit of an interface there with like the cervical spine and whether or not people have arthritis or different diseases or just even aging changes with relation to the spine and the paraspinal musculature. My patients have stiff neck for a different reason. Usually it's due to radiation that they get after treatment as part of their after surgery as part of their cancer treatment. And so that certainly radiation will give you pretty significant fibrosis of a lot of those muscles, and so they can have some neck stiffness, difficulty with extension for sure.
And talking about cancer, when you were first starting out, how hard is it to sit with someone down, a patient, tell them that they have cancer?
I think it's a skill that you learn and cultivate over time. I would say in my experience, and probably in most cancer surgeons' experience, you start doing this basically as a resident. No one's really going to have a medical student tell a patient that they have cancer, because obviously as soon as you say those words, there's a lot of other questions and a lot of other things that come to mind, and you need to be prepared to answer all of that. But you really start doing that as a resident while you're still in training, right? The public hospital side of my residency, the residents had a lot of ownership. Those patients really felt like they were mine. And I think one of the main things, to understand is to sort of communicate what you need to communicate to the patient, and also tell the patient what they need to hear with regard to what happens next. A very common phenomenon that you'll hear cancer doctors talk about is that you give the patient a diagnosis. Okay, I'm sorry, unfortunately, the biopsy came back as positive for cancer. And everything you say after that really kind of falls on deaf ears, because it's very hard to process that, right? Something that people have a lot of biases and a lot of preconceived notions about. Everybody knows somebody who had cancer, but you don't think it's going to be you. Right. So as soon as someone is telling you that, everything else that sort of follows, you're not going to pay a ton of attention to. And so, the important thing for me is just to keep the information as brief as possible, so that they just have time to process, so that they can ask the questions that they're going to ask you then, but really so that you don't lose focus, because when the cancer diagnosis is made, to some extent, you've got a little bit of a ticking clock, right? You want to, okay, we need to get these scans, we need to get these tests, we need to, discuss your case at our tumor board, et cetera, et cetera, et cetera, so that we can get a full and comprehensive diagnosis and then get the appropriate care thereafter. So I think it's not so much giving a cancer diagnosis at one visit. It's sort of cultivating the entire process of early cancer diagnosis and management and everything. Because the second time they come back to see you after that, it's usually, okay, I've dealt with this. Like, what are we doing next? Do we need another, scan, et cetera, et cetera, et cetera? Right. And at that point, the patient is really focused. And that's really when, a lot of the more constructive conversation happens.
Gotcha. All right. So now for people that don't know, including myself, I mean, I can tell you, I can count on my hands how many times I probably work with you, and it was probably just giving somebody a break, you know?
Sure.
And I only say that can you walk us through a typical day in the OR?
Yeah, so one of the things that I love about my specialty is that we have sort of very different flavors of days in the OR. I sometimes will do 4 or 5 real short cases. You know, each case is 10, 15 minutes. It's a biopsy, it's an endoscopy to take a look in the throat, et cetera. Or we can have one case that takes 10 or 15 hours, where we start in the morning, you know, and we got 1 or 2 surgeons working, you know, at all times, usually for the complicated reconstructions and everything like that. So I would say to take a representative day of really the essence of our specialty, I'll kind of focus on what one of those long cases will encompass. Okay. So let's say we have a patient who has an advanced cancer of their tongue or their jaw or something like that really will require surgery followed by radiation with or without chemotherapy, right? The tumor in the jaw, for the sake of the argument, obviously needs to be removed. We would also customarily remove the lymph nodes, the relevant draining lymph nodes in the neck. So there's tumor and jaw removal of the lymph nodes of the neck on one side and then on the other side, because we're going to be operating in the mouth and in the throat and putting a reconstruction in there and everything. There's going to be a lot of difficulty swallowing and a lot of difficulty breathing from all of the swelling and the acute surgery. So we'll also place a tracheostomy tube. So that's surgery number 4. We'll place a nasogastric tube to be able to feed the patient or go straight to a gastrostomy tube. So there's surgery number 5. And then we have to put the patient back together again. Right? So it's a central tenet of head and neck surgery that if you remove something, you do actually have to put something back there, which is different from a lot of other, you know, if you take a tumor out of someone's lung, you don't really have to put anything back, or their liver, or, you know, stomach, et cetera. Sure. But for head and neck, there's very much an anatomic reconstructive requirement, because you can't leave somebody without a jaw. They won't be able to function. You can't leave their neck, which is a sterile field, in communication with the mouth, which is completely contaminated and perpetually contaminated. So you need to separate these sort of body compartments, and that's where the reconstruction goes. So in addition to doing the removal of the jaw and the lymph nodes and the trach and the feeding tube and all of that stuff, then we're going to prepare the reconstruction, which we use usually a free flap for. And a free flap is basically, think of it as a transplant that comes from your own body. We're basically taking one body part, removing it, fashioning it to reconstruct something in the head and neck, and then using that. So let's say a fibular free flap. So we take the much less important bone in your lower leg, not your shin, but the fibula. We'll basically cut that, take a little bit of skin with an artery and a vein, and then that fibula bone will get cut and shaped into a new jaw. The skin that we bring along with that will basically reconstitute the area of the mouth where the tumor originated, which leaves another big hole, so we patch that up. And then now the person has a jaw again and has, you know, separation of their compartments. We hook up the artery and the vein from the leg to an artery and the vein in the neck, so that that whole tissue that we transplanted can be perfused. And then we close the patient up, probably skin graft the leg. So, you know, we're doing 7, 8, 9 surgeries here at the same time, which is why it can take 8 or 9, 10, maybe even more hours. But it's a cancer operation and a reconstructive operation all at the same time. Wow. That would be a typical day, maybe starting around 7:30 or 8 o'clock in the morning. Generally, we'll do that surgery with 2 surgeons, so that we can do work simultaneously a little bit. And then, you know, around 5 or 6 or so, we're getting the patient out of the operating room. And it's a long day, but it's an impactful day for the patient, because you get everything done at once.
Right, which I'm sure they appreciate.
Yeah.
And so let's go now to recovery. Is there any kind of a shock value or factor for the patient with all that going on?
There's an enormous shock value. And, you know, I'm not a doctor who sees a lot of patients. So in the office, you know, a patient who's getting that surgery or something similar, we'll spend, you know, a solid 45 minutes to an hour talking about this, because there's a huge shock factor. And I really wonder if you can even consent somebody really understand, you know, to have them really understand what's about to happen. Right. I basically tell them, look, this is going to be a huge operation. You're going to feel it when you wake up from it. You're going to feel like you got hit by a truck. And in a way, you know, gosh, you almost did, right? Because you have so many surgical sites and incisions all over the place. You're going to be in the hospital 1 to 2 weeks, et cetera. Your recovery is really, I tell patients, measure your recovery week to week, not day to day. You're going to have a lot of swelling and a lot of pain at the beginning, but eventually that will kind of come down. And long term, we do everything, with the goal of curing the cancer and giving long-term good function. I tell them you're going to feel much better a month after surgery, and then you're going to feel much better 2 months after surgery. And then long-term, we're getting you to a point where you should be functional.
Sure. Yeah. Wow. And with all those surgeries, what are one or what are many complications that could arise with all that?
There's a lot of complications that can arise from major head and neck operations. I'd say maybe the two most common are a threatening or a loss of the free flap, right? So if we transplant this tissue and hook up the arteries and the veins and everything so that everything has a nice blood flow in it, there's always a chance whenever you suture blood vessels together that they could develop a clot. And if that clot propagates and eventually blocks off blood flow, just like a coronary, just like a stroke, etc., whatever tissue was depending on that blood flow will start to die. So that's a surgical emergency. And if they call me in the middle of the night that my flap, looks like has a clot or it looks like it has a problem, we're going to the OR at 1, 2, 3 o'clock in the morning, opening everything up and checking and flushing everything out and trying to fix it. So I'd say, that would be called like a free flap failure. That would be probably the most common major complication that we expect, and probably occurs about 5 to 10% of the time, and most of the time you can fix it.
Do you notice with any particular patient or subset that happens to? Or?
Yeah, I would say the patients who that tends to happen to or at highest risk for that are those, one, who have a very large reconstruction and need a very large surgery, so they're on the table for longer, the tissues are exposed to the air for longer, et cetera. They're just higher risk for infections and complications in general, but obviously big proportion of my patients are smokers or heavy drinkers, so having vascular disease from smoking and from heavy drinking definitely increases the risk of that. And obviously patients who have other reasons to be hypercoagulable, to have much higher rates of blood clotting. And cancer by itself increases your coagulability significantly. And so that, the patient sort of walks into the hospital, into the surgery, and they already have elevated risk for this because they're chain smoking alcoholic who's got terrible blood vessels and has cancer. And so there's a lot of setups, but we're sort of in a desperate situation, so we need to take sort of desperate measures.
Sure. So like that's still not going to stop you from having to do the procedure.
Yeah,
right?
exactly. The alternative, if they're a candidate for surgery and within their algorithm surgery is going to be the benefit, you got to accept those risks, because the alternative is not, oh, don't do the surgery and you'll be okay. The alternative is you're going to die. Right. So it's death or a very, very complicated, risky, high risk surgery. Most patients, make the right choice.
Now, are you using any technology in your day-to-day to help you with these diagnoses or treat your patients?
Yeah, for sure. So I have a pretty relatively high-tech practice, just in terms of the tools that we use for our assessment. So in my office, for example, we'll see a couple dozen patients in a day, and we have a special high-definition fiber optic tower that we can use to look through the patient's nose into their throat and get an assessment of their airway, see the parts of the throat that you can't see. Your doctor's probably made you say, a whole bunch of times. And that gives you this much of a view, but we're operating back there, so we need the full view. So we have special fiber optic cameras that allow us to make airway diagnoses and everything in the office. We also have some instruments and everything that we can use to take biopsies and to, take samples or do, cleanups and debridements and wound care and things in the office that are maybe a little more technological than the average. So that part certainly is a very high-tech portion of what we do. And then in the hospital and in the operating room, there's lots and lots of specific equipment. We have, an operative microscope. When we suture those blood vessels together for reconstruction, we do that under a microscope, which gives you very good visualization. It actually lets you see the lining and lets you plan your incision so that you can sort of optimize your risks and make sure that the patient has a good outcome. We also use the robot, the Da Vinci robot, for transoral minimally invasive robotic surgery, mostly for throat cancers and the tonsil and in the tongue base. That's been a big development over about the last 15 years that has been expanded on quite a lot. And in addition to that, lasers for taking care of very, very early vocal cord tumors and vocal cord cancers, which is great, so you don't have to make an incision in the neck. You can sort of millimetrically laser the tumor off of the patient's vocal cord, and they can recover their function and have a good oncologic outcome as well. So lots of technology day to day, and a lot of sort of different devices to sort of become familiar with. It's a great specialty.
Great. And speaking about the microscope, I talked to other physicians, in my career, and you either love it or hate it.
Yeah.
So when you were in your training, that was one of those things, you just loved it because of the exposure it gives you and the way you can see the anatomy?
I think I didn't love it until I understood it, I would say. And I think that's a fair way of, a common occurrence in, in surgeries. You don't really like the part until you kind of have a handle on it. Sure. And learning surgery is very difficult, and I'm not that far away from when I was just starting to learn it, and so you feel like you've been good at everything, your whole life. You're a good student, you're a good med student, you do all this stuff, and then all of a sudden you go to day one of being a surgeon, and you just feel like you're terrible at everything. So I would say there's certainly a learning curve with the microscope. Some people will prefer loops versus the magnifying telescope glasses to the microscope. I use both, but I think what the microscope does, it's give you a choice of zoom and a choice of your sort of visual field, on a minute-to-minute basis. So sure. I think it's the superior instrument for microvascular anastomosis, for putting those blood vessels together. But there's an ample body of literature that shows that if you have high magnification telescopes on your glasses, the outcomes for free flaps are the same. But I think you get good lighting, and it's good. But in a pinch, on a mission where you may be somewhere where you don't have access to a microscope, the loops are great, and I use them day to day.
And they get the job done.
Yeah.
Okay. So let's talk a little bit about the human side of medicine. You mentioned that the patient connection is what really drives your work. So can you share any particular story, with regards to HIPAA, obviously? But
No. I think I had a mentor in residency who, when I was an intern, we were doing a case together, and he asked me, are you thinking about any fellowships? And I was thinking, well, I like the complexity of these surgeries, and, I was thinking of more the technical surgical side. And he said, head and neck surgeries are great, and they're fun, and they're complicated, and everything like that, but eventually it will sort of wear down on you, and really what you should do is become a head and neck cancer surgeon if you like taking care of the head and neck cancer patient. And I had never thought of it really in that way, right? When you're in medical school and you're an intern and everything like that, you're kind of shuffling through everything, just getting the job done, making sure everyone does okay, but you're not thinking about it from such a sophisticated philosophical level. Like, who are the patients you want to take care of? Which are the patient problems you most, I think you think are most relevant to your personality. So I kind of took that and put it in my pocket, and through the rest of residency, when I was on call and I would see a sinus patient or a pediatric patient or a cosmetic patient or a head and neck cancer patient, I could certainly see which ones I gravitated towards, even though the head and neck cancer patient might have been having a much more severe, life-threatening, complicated, dangerous problem. That was the one that I happened to like more. So that sort of human part of it is kind of what made me gravitate toward it. And I think as I've started my practice, that has really integrated. That was an excellent piece of advice, because it really, to some extent, the surgeries, eventually they become your routine. And, every so often you do a really great, interesting surgery, but most of the time, you kind of know what you're getting into. So really what it comes down to is, how's your relationship with your patients? Like I said, I follow them for a long time.
So for residents, you work with residents, right? Do you have any tips you can give them if they're going to have a day with you or be in your rotation?
Yeah, for sure. So I have second-year general surgery residents that rotate with me for about 2 months at a time. And so they are with me basically day in, day out, in the office and in the OR. And I basically try to tailor what our day-to-day is so that it's relevant to something that they might see in a general surgery practice, like neck trauma and, and thyroid and endocrine surgery and things like that, and just being comfortable with, again, a quite complex area in the neck. And so what I've basically told most of our residents is just, you want to transition from the role you have as a medical student, which is sort of being a fly on the wall, maybe asking some questions, but otherwise just studying and showing up and everything. It's almost a passive role. You need to transition to having a very active role. You need to take ownership. You need to understand every step of what's happening, because ultimately in residency, you function as this intermediary with between the patient and the attending, and you end up your education basically found within that space. And so I just tell them, look, you should have at least an understanding here to take ownership in case I vanish today. You have to take care of this patient. You should have that sort of understanding, and it changes how they think about it, and it's sort of, what would you do? We have a patient who has a given problem here. What's your plan? Let's say I'm not here. What are you doing? And when the first time someone asks you that, and you all of a sudden become the senior most person in the room who has to make the decision, and everyone looks at you, then you need to have a plan, and that's a really humbling experience. So we try to do that in a controlled fashion, certainly early in residency, so that you get into the mindset of thinking, well, what are my options? What's number one? What's number two? What's number three? Do I need help? Do I need fluids? Do I need blood? Do I need a drake? Do I need et cetera, et cetera, et cetera? Because this more second nature that is to you, the more you're going to be able to mitigate the inevitable sort of complications of surgery.
Right. Is there any tips you want to give to perhaps if a patient sees this, and any advice you can give them beforehand?
Yeah, I think the most effective piece of advice for patients is you need to trust your doctor, and trusting your doctor means you should recognize that they're taking ownership of the problem, taking ownership of your case, whether they're your primary doctor, whether they're a specialist. You need to feel like you are the person who's across the exam table from you is competent, trustworthy, and they're explaining everything to you in a diagnosis and treatment sort of method. And patients know this. I feel you kind of know when you're comfortable with somebody. But I would say, rather than having a ton of technical specific questions from Google, right? Tune in on whether or not you feel like the doctor's taking ownership of your problem, and whether they're talking to you in, this is your diagnosis, or we don't have a diagnosis, so this is what we need to do to get a diagnosis. Okay, we've got a diagnosis, now this is your treatment and why. If you have somebody who's taking care of you in that manner and you feel like they're taking ownership of it, don't ask too many questions. This is the person you're gonna want to stay with. Sure.
All right. We want to talk about advancements in your field of head and neck surgery. So what are some advancements?
So being a a very multidisciplinary sort of practice. We work with radiation oncologists and medical oncologists as part of the whole treatment teams. I'd say one of the biggest advancements right now has actually been using medical treatments for head and neck cancer. Historically, a very surgically and radiation biased sort of treatments. But with the advent of immunotherapy, which are sort of infusions given by the medical oncologists that help the immune system identify and reduce or reduce tumors or make them go away, I think that's definitely one of the biggest improvements that we've had. The trials usually happen in patients who are widely metastatic or have very advanced sort of terminal cancers, to see if you can lengthen their survival, lengthen their time, and then over time, as we see success with that, then the therapies can become available to earlier stage people where the standard of care works reasonably well, and maybe there's a chance to improve on that. So I would say the number one in advancements in future directions for head and neck tumors is using immunotherapy to sort of reduce the size and severity of the operations that we do. Just the same way that we sort of laugh now about how they used to do amputations and things, surgeries in the early late 1800s, early 1900s, and we see that as barbaric. I suspect that hopefully in 50 to 100 years, we look back at sawing out somebody's mandible and sewing their leg into their face. I hope we see that as barbaric, because our targeted treatments have become such that we no longer have to do those operations, or just not do them as frequently, or do a smaller, give the patient the opportunity to have a smaller operation. Sure. Within the field of surgery itself, I would say continuing the exploration of minimally invasive techniques for a lot of the cancer-specific sites. Endoscopic nasal surgery for sinonasal tumors and skull-based tumors has really grown a lot, and I think has had some significant improvements in technology with navigation and the endoscopes and everything. Tumors that used to require an incision where you'd basically open up the lip around the nose, under the eyeball, and sort of open someone's face like a book to get access to. We can do some of those now, endoscopically with some assistance. So I would say that, and the continuing advancement of robotic surgeries, I think, are going to be places where we're going to make a lot of progress. But like I said, I think the most important thing from the patient standpoint would be if we can continue to have improvements in targeted therapies so that the surgeries can be smaller. Yeah.
Is it true that patients that are bow-legged do better because of the natural curvature?
I don't think so.
No,
No, because we actually impart our own curvature. And I know, so you're going to have to tell them that all that time they spent making their bow leg bowed is, it's not going to help them that much.
Not going to help. Burnout, right?
Yeah.
Because as you mentioned, you have some procedures that last 10 to 15 plus hours.
Mm-hmm.
So how many days are you in the operating room? How many days do you operate?
My schedule is a little bit erratic. I'm in the operating room every Tuesday, most Wednesdays, and I would say every other Fridays.
Oh, okay.
Every so often I'll do a case on Monday, but usually that's a clinic day, and then Thursdays are my protected sort of full clinic day. So I would say anywhere from no less than 2 times a week, maybe no more than 4. And occasionally, if I'm on call or there's lots of emergencies, I might spend all week in the OR.
Sure. Wow. Yeah. So then how do you deal with that emotional toll and the stress and avoid burnout?
Yeah, I think burnout is obviously it's a hot topic right now amongst administrations and hospitals and healthcare workers across the entire sort of spectrum, especially after COVID. But I think the way that I personally mitigate burnout is try and have sort of solid quality time off, protected time off, keeping everything such that when I leave the hospital on a Friday, everything is in its place and I'm minimizing the chance of getting called about, something. And sort of a lot of anticipating like what might this patient need going into the weekend? Are they getting sick? Are they not, et cetera? So take care of it now so that when you're off, you're off. And there's there's now a lot of literature on burnout, and there are some sort of standardized best practices for that. And I would say just making sure that when you don't have to work when you are not planning to work. So you're at your kid's birthday party, you're not expecting to get a phone call from work, and someone calls you, gosh, that's just the worst.
Sure.
And, having quality time off spent. So go and, doing activities, your hobbies, spending time with your family, going out, doing whatever it is that you want to do, but being able to sort of do that in a protected manner. It's kind of what I would say is the best.
And how important is it to have good partners?
I think it's key. It's absolutely critical to have good partners, because if you don't, then you're the sort of person who's there all the time. And that is, that's a guarantee. That's an absolute guarantee that you're going to burn out and start to resent, things you looked forward to, right? The problems you are trained to help, people can become burdensome, and that's a hard road to reverse. But I think having good partners who are capable, who you can trust, you can sign out your patients. Hey, look, my partner's on call. If anything happens, they're going to take care of it. For head and neck cancer surgery, I think it's key.
Right, absolutely. Yeah. And so what's one thing you like to do for fun when you're not on call?
So I like to go fishing. I like offshore fishing down here in Florida. Inshore fishing, I would say that's probably what we do most frequently. My wife and I have a 2-year-old, and so we've traveled some. But I would say definitely traveling is something that we're going to come back to doing much more frequently, maybe after kid or kids are a little bit older. But yeah, fishing and travel, I'd say, is probably the main.
Nice. All right. And now looking ahead in the future, what do you think the future holds for your career as far as in your specialty with technology? We have the new robot coming soon to regional. How excited are you of that?
I think it's going to be a very solid addition. Obviously, there's been a lot of development. They've learned a lot with the prior iterations of the robots, and I'm on the robotic committee at our institution. And from my standpoint, from the head and neck surgery standpoint, the robot really is not very complex. We use it as a means of sort of getting into the deeper part of the throat that you couldn't do otherwise, or that you would have to do with a very much more morbid open surgery, which we're not actually doing very frequently anymore because of the robot. So I think continued marginal improvements in the robot's ability, I think, are certainly in the future. Sure. But still, the bulk of our surgeries are going to be done sort of old school with an open incision, scalpel, and cautery, and everything like that. So I would say in my career, I like the idea of building and developing things. So we're pretty plugged into expanding our service line within our institution and making sure that we can reach patients across different different space and time within the county and beyond. So I would say growing the practice, growing the number of surgeons we have, the number of advanced practice providers we have, just so that our presence can be a bigger part of the organization, I think is key. Where I trained ENT and the head and neck departments were very large, very established presences within the health systems, and that gave them a bit of economies of scale in terms of their ability to provide a comprehensive service that I think is what I want to work toward in my organization.
Nice.
Yeah.
And now stepping back to the OR, is there anybody that you work with you want to give a shout out to? Anybody, your team members?
Yeah, we have a lot of our team members, and I think we've been doing a good job of this lately, has been to sort of keep the same people so that we're scrubbing. Juliet certainly keeps our entire operation going well. Monica, Faishan, all of our techs, and I think having ENT is a very specific surgical specialty that not a lot of people in tech school really get a lot of exposure to. Everyone knows what a DeBakey is and can probably scrub a gallbladder. But sinus surgery, skull-based stuff, micro, it's a completely different animal. And so I think having them and being able to consistently work with them, I think it's fabulous.
Great. And you're right, because in school you really get the general concept of surgery, and like you mentioned, some of the basic instrumentation, some of the basic surgical cases, hernias, gallbladders. You don't really specialize in head and neck or cardiac or even vascular for that matter until you're actually out in the field. Yeah. But that is good. So the continuity of having the same people, what makes probably your job in surgery efficient.
It makes it even doable. You have somebody who's never scrubbed a free flap or done microvascular anastomosis. Right. It's even borderline risky to do it. I've trained a few techs in micro, but when you think about it, when you take that piece of tissue, the flap from the arm or the leg, and you cut the blood vessels so that you can move it up to where you're going to do the reconstruction. From the moment you cut those blood vessels, that tissue is ischemic. It's dead until you hook it up again, and that hookup works. Right. So we sew it in, we get it all into place, and then we're putting the artery and the vein together, and we time that. And our ischemia time has to, it's usually between 30 minutes and 3 hours, depending on what we're doing. Right. But that is the stressful window, and that's when the team has to be, solid, lockstep, no counting, no one leaves the room, no one, no relief or things like that, because all of that can lead to changes and everything, which just incrementally increases the risk of you having a poor outcome.
Absolutely. And one thing I want to touch on, this is going to be the last part of our serious moment here in the podcast, is HPV. We mentioned that before we started this, that we want to talk about that.
Yeah. So definitely a huge part of head and neck cancer, and a very rising sort of segment of cancer in young people and non-smokers. So, HPV, the human papillomavirus, is a large family of viruses that are basically transmitted through human contact. So like warts are papillomaviruses. And then there's a couple of segments, namely number 16 and 18 of the however many there are, who have significant risks for causing cancers. And so we initially saw that in cervical cancer, and so the vaccines came out to basically vaccinate girls against HPV because of cancer caused by a virus, which would be preventable or largely preventable with the vaccines. And so as we've realized that many other sites were getting HPV related cancers, sort of amplified the vaccine's indication to boys and to adults and young adults and everybody. And so basically exactly how cervical cancer, upper GI cancers, lower GI cancers, and throat cancers, they're all sort of in a group of HPV-related disease. And so what happens is you're exposed to the virus, usually through sexual contact, and it often happens relatively early during sexual contact, because it is just such a ubiquitous virus. Something like 95% of adults are seropositive for HPV, one of the HPVs at least. And so if you're unlucky enough to get one of those two subtypes that predisposes you to cancer, then you have this risk, and it's not even the smokers and the drinkers who are getting it. It's a 30-something, 40-something-year-old person who's had a few sex partners throughout their life, as is typical, and then now they have a cancer growing in their tonsil or in their tongue base and everything. And so the main difference with those cancers is that their outcomes are actually much better. The prognosis is much better compared to the same cancer in the same location not related to the virus. So if a smoker has a smokers related throat cancer in their tonsil,
Sure.
Their outcome or their likelihood of being cured is much lower than that of the P16
Wow.
HPV, human papillomavirus related cancer. And so that's certainly something to keep in the back of your mind, because they're so different that the staging is actually different for them. But the cancer with the better prognosis, the HPV cancer, is rising really relatively rapidly. And I'm hoping that as people continue to become vaccinated, and we vaccinate boys and girls before they are sexually active. So, I mean, vaccinate them when they're 9 or 10, and they're protected before any sort of, typical sexual activity begins. Hopefully this will be sort of a temporary bump in an illness that long term, with high vaccination rates, we might even see completely eradicated. I think that would be marvelous. But obviously that's advice I'm giving to my patients every single day when they tell me, what should I do about this? I said, we're treating yours, vaccinate your kids and your grandkids.
So far in your experience, your career, you have not seen anybody with the HPV virus that had the vaccination.
Yeah, it's very, very rare.
Very rare
to see that. And the problem is that the vaccines just came out in the late 2000s, kind of early 2010s, right? And so we're still in the process of seeing these people grow up. But having the vaccine prevents the infection from, in the first place upon your initial sort of exposure to it during sexual contact. And there's even people studying whether or not giving the vaccine as an adult after exposure or even during treatment can actually be helpful. So we look forward to seeing the results of those trials, because there may be a reason to vaccinate people during treatment and after. Early days still, but those studies are ongoing.
Wow, that's great.
Yeah.
So now it just adds one more thing to the list for all our single people. When you're out and about, you got to ask them, first of all, what do you identify? Is that your body parts? And do you have HPV? And a list of other things. But is there, right? Is there any symptoms when you have the HPV besides like if you had a nodule and it grew?
Yeah, no, there's really not too many symptoms per se from the oncologically associated HPV, viruses. You kind of catch them like you would, any other. If you have the variants that give you genital warts, for example, the symptom will be the warts, et cetera. But,
Gotcha.
But as far as oropharyngeal cancer, there isn't really anything. The main symptoms of oropharyngeal cancer are, a neck mass, which is usually that, you have a small tumor growing somewhere in the throat. A couple cells go into a lymph node in the neck, and that's maybe the most common way that people will sort of present. Like, I have this lump here; it's been there for 2 months, and and then we work that up. Sore throat that lasts for more than 3 to 4 weeks. Also a problem, swallowing difficulty, voice changes, breathing difficulty, etc. It's an area where things tend to be sort of symptomatic. It's not like the pancreas or other places where you can have something grow for a while and really not be aware of it.
Right, I have no idea. Yeah, that's scary.
Sure is.
Okay, well, let's get back to our fun questions here.
Let's do it.
I'm going to finish off the episode with these questions. I can't see nothing. I know I look funny with these glasses, but my prescription glasses, I put them in another bag. So we talked about the favorite music. Okay, so people that know you the best say you're an aggressive dominoes player. You're the world-class dominoes player from Little Havana. Is that true?
That is 100% true.
Okay.
Yeah, I play dominoes very frequently on Wednesdays with my dad and
no kidding.
Another group that will remain unnamed.
Okay,
but yeah,
I won't say that.
Professional.
When people mention they're Cuban and they're from Miami, the first thing that comes to mind is Cayocho, Mambo, Coraditos, Arroz con Pollo, and Donald Trump. Is that?
Yeah, I would say if you walk up and down Cayocho, that's exactly what you're going to get. Absolutely.
And incidentally, who you're voting for? Do you know?
I don't know yet. I think I'm voting for the couple of relevant Florida amendments. But honestly, I'm pretty disappointed by both sides, and pretty sad that this is the best that we can do.
There you go. And there's some people wanting us to put politics. There's our politics segment.
Our politics.
That's it. We don't get any further.
Yeah, give up on politics because they all suck.
Right. And finally, and this is a very important question, a lot of people watching this at home want to know, what is the beef between Cubans and Puerto Ricans?
I don't know. I think we're just trying to be the MVPs of the Caribbean. And then, Dominicans also want to be MVPs and everything. I think we sound similar and have similar foods. But I don't know. I think it's mostly love and having a wonderful satirical sense of humor, which I think is just absolutely ingrained in Hispanic culture.
Right.
And yeah, everybody does everyone gives them everybody else reasons to make fun of them.
Right.
And in the Caribbean, we're going to exploit it and get over it.
Now, finally, who's the inventor of salsa?
The inventor of salsa was some unknown Afro-Cuban percussionist who created those rhythms in Africa. They were brought to the Caribbean during the slave trade. And those percussions really were the sort of backbone foundation of what became el son, which is what Cubans would call the formal name for that beat that is Cuban salsa. And I think at that point, man, it's hard to know if there was one person who did that. But it certainly, I would say, was born as a musical genre in Cuba, and then had a lot of spread to Puerto Rico, to Colombia, to New York, and then to the United States, and then the world as a whole, because it's absolutely infectious music. But the person to take credit for them was whoever invented the percussion, and I would say that's sadly unknown Afro-Cuban percussionist.
So we're going to go with the Cuban people, because I have some Colombian friends, and they all try to claim it that they started the salsa. So there you go. There's the answer.
Yeah, the answer is Cubans invented everything, as they will tell you.
That's right.
As we will tell you.
And now, do you make a Cuban sandwich at home? Do you know how to make Cuban sandwiches?
I don't know how to make a Cuban sandwich at home. I can make Cuban coffee at home.
Oh,
that's a
okay.
staple.
That's
and
nice.
an art form with the old.
It is, right? We got to whip
with the whipping of your sugar, so that you have an espumita. And if you don't have espumita, get out of here. You don't know.
You don't know what
your
you're
Cuban
doing.
coffee's whack. Get out of here.
Get out of here. No more that fake stuff here. Well, I mean, that's our time. I do appreciate you spending time with us and sharing your journey. For you at home, if you're just tuning in and this is your first episode, this is really what you're going to see. We appreciate if you can share. Our goal is just to inspire people, give them information of different people's career and how they got there, and of course some tips and advice along the way. So I want to thank you, Dr. Selman, for joining us, and you at
Thanks
home.
for having me.
We'll see you on the next episode. I'm Steven Perano, your host. This is the Cyber House Podcast. Take care. Thanks. Appreciate it.